Then we'll get started. As usual, we're going to record. So if anybody can't make it, and your colleagues can't make it, they'll be able to watch back the whole recording or just bits of the recording. It's up to them. So we've got quite a full agenda today. Lots to get through. To look back again at the feedback from the first meeting we had and listen to what you guys wanted, and a lot of that was centered around listening to good practice, finding out what other people are doing, but also the one specific ask was linking to external organisations. So we've asked Julia, Dalia and the team at Kinsmed to come along, and that's going to be more of an open discussion about how we link in and how other people may have already linked in with external organisations that are providing these great services out in the community, but we don't necessarily always know about that. So we've got 20 minutes from the team with South Warwickshire, Cam and colleagues, Helen, Tracy. They're going to give an overview of some of the work that they're doing in South Warwickshire. Then we're going to have this open half an hour, so 45, see how long it lasts really, but more of an open discussion. There's no agenda on that one. I'm going to ask Julia, Dalia and the team from Kinsmed to introduce themselves first in that session, and then I'm going to open up to you guys to ask lots of questions. So have a think about what are the questions you may want to ask, if any burning issues or things you want to find out. Essentially, so how do we get better at connecting with these community groups that are providing these great activities, mobility activities for people in the community. Then we're going to go over to James Paget, and we're going to hear from Rachel Crane, who's going to share some information around bereavement support worker role, and then Joe McCauley from Nottingham is going to wrap us up with some training resources, 15 minutes on some training resources that the team at Nottingham have developed. So lots to get through. Hopefully that's useful. As usual, we'll share the slides afterwards, so we'll be able to circulate those, any information that you may have missed. Chat is open, so if you want to ask questions in there or post any comments, say hello or whatever you want in there, that's absolutely fine. You can do that. But for now, I don't know who's going to run the show, Cam, but I'm looking at you to lead us off with all the great stuff you're doing in South Warwickshire.
Hi everyone. So I've got the lovely Helen, she's the ward manager on Victoria Ward, and the lovely Tracy. So they're both going to be presenting to you. Let me just share my presentation. We are having some technical issues in Swift, so if we lose anything, Nick, it might be that I might have to ask you to start sharing, but we'll give it a go. Right. Can everybody see that screen? Yeah. Can everyone see my screen?
Yeah, all good.
Yeah, is it big enough? Yep.
If you can go on to slideshow, that'd be great.
Yeah.
And then Timothy Withers.
Just going on that. Right. Okay. Is that okay now? I've gone on to slideshow.
Just click on from the beginning. Or from.
Oh yeah. Okay.
That's it. That's better.
Is that okay?
Brilliant.
That's fine.
Brilliant.
Okay. I'm going to pass you over to Tracy. So Tracy, if you can carry on and come in, and then we'll change the slides as we go along.
Okay. So we have implemented a new movement system on Victoria Ward. So Victoria Ward is a care of the elderly, frailty, long stay ward.
Is he the one?
Can you hear me?
Yep.
Yeah,
good, really good. Sorry. So this new system came about because we had a RCA with a pressure sore that had accumulated on a patient of ours. I was in post for 12 months on Victoria last year into this year, and what happened was, Cam, can you move the slide across, please? Basically, from the first time that the RCA I did on the first week of me starting to 6 months down the line, the omissions in care that were highlighted from an RCA the following time were exactly the same as what we'd had in the previous. And at that point, we'd looked at things like training for the staff, getting tissue viability involved to try and get them to come and do some on the spot training with the staff as well, looking at our paperwork. But obviously to be sat back in a meeting with the same learning outcomes as we'd had before made us start to think we needed to do things very differently. And this all came about from just talking with the staff, namely a couple of healthcare assistants, one being Duncan, who's our band 7, and Jackie, about how we could improve things from their perspective. So the outcomes that we got that we needed to look at were things like the paperwork, and the fact of how it was graded on admission, how we communicate between the staff, and one of the big things was that we weren't documenting whether patients had been lying side to side, and sometimes that's because people were refusing, but we weren't actually documenting that. So these were our outcomes that we wanted to look at and to face. So this then brought us up to thinking about how we could do it that was visual, that we could use, that everybody could use and could identify with. So we came up with this traffic light system. And so we looked at red being the most significant patient that needed the most care, to green being the patient that is moving around. So we categorised it, and it took us a little while to work this out. We worked really closely with tissue viability with this one. So we looked at red and we looked at what we needed to do. So we were looking at these patients being your extremely high risk. So your really frail patients, you know, Waterloo, really high, sort of over 20, 23, 24 above. Patients that were not able to move on their own, needed people to, you know, reposition them even in the bed. We worked with tissue viability, and they decided that they wanted the red to be your category 3, 4s or the unstageables. So we put that in, and we decided that we'd make it so that if we were scoring somebody on a red, we'd make it that those patients needed to have an air mattress, and the best we could get within the trust at the time. We looked at making it uniform so that skin had to be checked a minimum of 3 times a day by a trained nurse, and that we weren't to sit patients out in the chair, because what we were finding was we were sitting these patients out in the chair, and then time would elapse, and that would obviously cause them harm. Looking at profile in bed, which we did some education on, because that obviously wasn't something that was being done on the ward at the time. And then the ward link nurse was used as assessment and for further advice if needed. So that was how we scored a red patient. So the red amber, which was the one that tissue viability wanted to put in, was for a high priority patient. So again, you're really frail, needing support, needing help to move in the bed or in the chair, but not your category 3, 4s. So we're looking at Waterloos that are above 20, air mattress again, at least 3 times a day. So you can see there's quite a lot of overlap between these two. The difference with this is that we could sit people out for a maximum of an hour at a time, and we'd ideally look at meal times for that, obviously to cut down on risks of aspiration when they're eating, and to encourage side-to-side lying in the bed. So there's quite a lot of overlap, as you can see, from red to red amber, but for us, tissue viability really wanted the distinction between red and your STIs, DIs, and your already pressure 3, 4s, to the different one there. So yellow, we've scored patients as Waterloo 10 to 19. So they're able to do some themselves, move around, some of them, sorry, my tongue's getting tied. They're able to move a bit in the bed themselves, but they are at risk. So not such a high mattress required at the time of admission, but obviously to keep an idea and to keep a note so that if that changed, we document that, and we obviously upstage them then to a yellow, red, yellow. And profiling the beds, and they could actually sit out for 2-hour intervals rather than just the hour or not at all. And then green, as you would expect, is for our independent patients. So Waterloo up to 9, normal foam mattress, daily skin check, and just educating, repositioning the bed and the chair. So as you can see from, we've also included a movement board. So what we found as a team was that the patients were being sat out, maybe by the physios or by, you know, one of the members of the staff, and then it got busy, and then the patients would be sat out for longer than what we would like them to be. So we came up with this idea of having a movement or sitting out board, which is by the nurses station, which has the bed space of every patient, and then against it, it has a time when people sit out and then a time when people get back in again. The thought process behind that was that we would, as a whole team, be aware of how long a patient had been sat out for, and not just the nurses that were in that bay at the time. In the hope that if a doctor went to review a patient and they could see on the board that they'd been sat out for an hour, they'd be highlighting to people, look, we've just seen this patient, they've been sat out for an hour now, have you got time to get them back in again? What do we need to do? Or the physios or whoever was in the bay, because obviously each bay, each area is different and has different priorities. So it was hoped that if the whole ward knew how long patients had been out in the chair for, then that would mean that they could be put back into bed or position changed in a timely manner. So the implementation, so we initially tried it for 3 months. So what we did was, when the patient was admitted to the ward, each patient was assessed for traffic light, so what colour they would be. So when we were admitted the patient to the ward, we were looking at how the person's skin was and looking at how their mobility was, and then working out what colour traffic light they would be. And this was also put on the movement board by the nurses station. So for example, if we thought that somebody was yellow, we've got little pictures of traffic lights in all the different colours. So we've got red, amber, yellow and green. So if someone was deemed to be yellow, they'd have a yellow traffic light put above their bed, so that's there for everybody to see as soon as you walk in the bed, so it's very visual. And also then on the board where the movement board is, we'd have a yellow dot, which would imply then that we then refer back to what is required for a patient who's scoring as a yellow traffic light. Can you go back a minute, Cam? Sorry. I think the thing about this was that we literally engaged every single member of the team. So we started off with the idea that we were looking at changing how we did things, because we were all saying it wasn't working and we were worried about our patients, but we hadn't really sat down as a team and thought about how to do it. So once we'd come up with the idea, we then went to the team and they kind of developed it further. So they're the ones that came up with the movement board. Quite a lot of the CSWs came up with the idea that if they had something visual where everybody could see when a patient had got to get out, that would also help. So I think a lot of the, for us, it's worked so well because we kind of got everybody engaged from the ground up. And it says they're trialled for a month, but I think it ended up being trialled for 3 because we felt after a month that it hadn't really had enough time to work. And then we got feedback from the whole ward, not just from the staff on the ward, but also from therapists and the doctors as well, and the patients where we could. Yeah, thanks, Cam. Oh, you've missed some out, I think, haven't you?
It was 10 slides, Tracy. That's
So, yeah, there's one at the end. So the initial feedback, that's it. was that all the staff felt that, well, the staff
Yeah,
that
so
were
we
based
see
here
the
initially all
people.
felt that it worked really, really, really well when they were short-staffed, or when there weren't the regular staff that they're used to on the ward. So Victoria went through a phase where we were running on quite a lot of agency and bank staff. And so I think a lot of our permanent staff felt quite a lot of pressure to make sure that everything was done. And by implementing this traffic light system, it meant that as long as we'd explained to the staff when they arrived on the shift every day what the traffic light was, that everybody seemed to work towards it. And it, because it's quite visual, everybody knew what was required. And although it seems to be quite prescriptive, we obviously encourage people to have to use their own clinical judgment, and we quite stress that quite a lot when people came on the ward, because somebody could be, you know, a yellow one day, but actually once they start to feel better could become green. So although it clearly states what the sort of bare minimum requirements are, it wasn't written in stone, and it could be moulded for each individual patient. I think the thing we're struggling the most with is that, and even still now, is that the movement sitting board isn't effectively being used. It's not consistent. So I think that some people put the times when they get patients out, but not everybody does. I think the vision going forward is that we really want it to become an MDT approach, where there's more engagement with the physios, OTs, doctors. It's still quite reliant on the nurses being in control of when the patient gets up and gets back in again. So that's definitely something we need to keep working on. As I said before, I think because we engaged the staff from the beginning, it's been a really positive change to the ward, and they've taken ownership of it, and it's been tweaked, as everything is. But fundamentally, it's proven to be a big change for us, and a very positive change for the patients. I think I'm right in saying we haven't had an RCA of any description since this has been implemented, and this was implemented 10 months ago, 11 months ago? 11. Yeah, 11 months ago. So from our point of view, it works. Thank you. It works really well. And it seems to have been able to be adapted for all the different members of staff, whether it be bank, agency. What I haven't said there is not only have we got the traffic light above the bed, but in everybody's bedside folder, there's an actual handout of what each, so the slides that we've shown you, the red, amber, yellow, green, it clearly states there, if you're scoring that on your patient, then this is what you need to do. So I think it gives people a bit of guidance, and especially we've had quite a few OSCE nurses and newly qualified. I think they've benefited from it because it gives them a little bit of support in how they deal with our patients on the ward. And another problem, I guess you could say, is that initially we did have to tell the staff about it over and over and over again, but I don't think that's the end of the world, because I think actually the results kind of speak for themselves, and it has changed how everybody works. And if it is really short-staffed, then, you know, the staff are going home knowing that they've gone to the patients that need them the most, rather than start historically we'd start one end of the ward and work down, rather than looking at what the needs were potentially. And for us, it's worked amazingly well. And everyone's really positive about it. And what started off as a trial is completely embedded, I think, into our ward now. And we've worked really closely with Tissue Viability, and they seem to like this as well. And yeah, in a way, we're very proud of it. And it's good that we had this kind of kick, if you like, to do something better for our patients and not just sit back and go, okay, we'll just do the training again, or we'll do, you know, this, that or the other. I think because we've got people on the board that actually cared, it helped to implement this. And once we'd got the kind of the basic idea of a traffic light, the rest of it just kind of developed itself.
Thank you, guys. That's really, really interesting. I think there's a couple of things for me. Anybody else got any questions, please pop your hands up. For me, I agree. I think that the traffic light is a well-known reference point in terms of the need to do something. I think what you picked up on, I think, is quite interesting. We often find that there is warnings. There are things that we're telling people in terms of an instruction, but we don't necessarily always give the help and the advice about what we do about it. So we can rate something or we can score something, but it's the so what, you know. So I think that helpful. I mean, I know it's not necessarily on the slides, but that thing you describe where if somebody is red, extremely high risk, it's not saying, you know, that they completely write them off, they can't do anything, but there is some things that you possibly could do for those patients to keep them moving. And I think that's the interesting bit for me, is it's the so what bit in this, which I think is helpful. I'm sure there'll be lots of people who'll be interested. Claire's already put in the chat about she's gonna have to drop off, so she's going to share that with her tissue viability team, and I'm sure others will be interested. And if you don't mind, people will be picking up your email from this chat, so if you don't mind the odd email here and there from people, I'm pretty sure you might get a few requests for some of that material, if you don't mind sharing.
Yeah, okay.
No, we're happy to share, Nick. That will be fine. Also wanted to just quickly mention that we're relaunching End PJ Paralysis from the 8th of December. So we've got Brian Dolan coming to Swift as well. So that starts then. We've also taken on 2 activity coordinators that start on the 18th of December. So that's all to help with reconditioning. So we're actually doing a Christmas activity week with loads of fun games and activities in there. So we'll discuss at the next forum how that goes, but it's a nice way of moving forward. And the Good Morning Wave, which we got our first gold medal for, we're going to relaunch that week as well. So some of the ideas that we used first that we got gold medals awarded for, we're putting that back into practice and seeing if we can do more with them. Brilliant. But we're in, so that's our way forward.
Thanks. Yeah,
Thank you.
I know some of you got to drop off, but if anybody, Cam or Helen or Tracy, let's have a look at the chat. If there's any questions in the chat, I think Anne-Marie's put a question in there as well, that if you can just pick that up, that'd be great. And I think Viraj as well put something there as well. So I'll leave that one with you just to respond to those questions. I think you have picked up the question from Anne-Marie already. Brilliant. Thanks, guys. That's really helpful. I did speak to Rachel this morning, Cam, and she said you were doing another MPJ Paralysis as well. So again, to you and everybody else, all the materials are still available from the reconditioning game, so you can feel free to use that. Brilliant. Thanks a lot. Okay, so we're going to bring in Julie, Dahlia, and I think it's Max, and I don't know your colleague's name, but we'll bring in you now. This is very much an open discussion. It may last 10 minutes, quarter of an hour, it may last 3/4 of an hour. It depends on you guys as an audience, depends how much you want to find out. One of the things that did come out, as I mentioned before, about from the original meeting we had when I asked you what you think would be helpful, was how we can connect with organisations like Kinsmed, Move It or Lose It.
I'm just listening to
that's
reconditioning as I type.
If you're not on mute already, that would be great. Gemma, I think you're just on it. Thanks very much for that. So what I wanted to do is just create a bit of a sort of open floor, really, so you can ask questions, find out a bit more. I didn't really want to make this a presentation thing because, you know, that can get a little bit on top at times. So I was just going to ask Julie, Dahlia, and Max and colleague to just do a quick 5 minutes intro into who you are, what you do, you know, any kind of existing links with the NHS or social care or any healthcare environment, just to give a bit of context, and then we'll open it up to any questions. And I think what I'm really sort of steering this towards is, how do we find those mechanisms, those ways, those connections to we find ourselves often we find ourselves trapped in this, we're not allowed to, or we can't do, or how do we do it, whatever it is, and we find ourselves stuck in these rules. But I know from Claire, who's had to drop off, who's been Telford, she's worked with Julie before. I know Dahlia has worked before with organisations and Kinsmed, so we know it can be done. It's just, I get the impression it can be quite difficult and probably bureaucratic at times as well to make this happen. So this was an opportunity as ambassadors to try and break some of those rules a little bit and see maybe we can knock down some of those big walls that we've got. So Dahlia, I'm going to come to you first, if that's okay. Just share a bit about yourselves and what you've done. I know you've been involved in some research as well, so that'd be great.
Yeah, I shall try to be reasonably brief. So I am the head of business development and marketing at Aesop Arts and Society. We are a very small national charity, and we work using the arts in an evidence-based manner to solve specific problems in society. Our exemplar programme is Dance to Health, which is a falls prevention programme with a difference. It's been running in its current form, more or less, since 2017, and has many sustainable groups across the country, including across the West Midlands, in Wales, in Norfolk, Sheffield, etc. So what we do is we start with PSI. PSI, I think most people would know, is reasonably effective, and it is the perceived route through the NICE guidelines to build strength and balance. But the downside about it is that participants often call it dull. They 81% don't complete even the first 12 weeks of the 26-week programme, which is the minimum. And then if they stop, and there are very few ongoing programmes, then all the benefits have been lost within a year and a half. So there's some big problems, and what we wanted to do was find a route to resolve those issues so that it was as effective as possible and allowed people to use their creativity as part of that. So Dance to Health, we take professional dance artists. So, for example, there's one of them who used to be at Birmingham Royal Ballet or whatever. They're not all ballerinas. They're all sorts of different kinds of dance. And then they also have experience working in the community. So they know how to interact with people effectively. And then we actually send them to be trained in PSI. So they have the same level 4 qualification as an NHS physiotherapist. And then once they are fully qualified in PSI, we then do our translation training, which essentially, well, you could say that it embeds that PSI into the creative dance, or you could say that actually they're smuggling it in, because the upshot is that when participants take part in Dance to Health, they're dancing, they feel like they're dancing, they're having fun, they often call it joyous, they really, really enjoy it. Very few people who start Dance to Health want to leave Dance to Health. Our attrition rate is incredibly low. And I'm just currently evaluating exactly how low it is, but it's I can tell you that it's really good. And so what that means is that it's incredibly effective, and people stay, but they don't feel like they're doing strength and balance training. They don't feel like they're doing physiotherapy, and that's really important. So it was independently evaluated, as Nick says, by Sheffield Hallam University. And what that showed was that it reduced falls by 58%, which is fairly significant. I think you'll agree. It's significantly higher than PSI on its own. It also reduces the severity of falls. So normally, in those aged 65 and over, if they have had a fall that requires them to go to A&E, 35% of those people would become an inpatient. only 13% of our participants become an inpatient. So it's dramatically reducing the severity of those falls. And then, of course, it has all these other benefits, 96% improvement in mental health, 96% improvement in physical health, 87% reduction in social isolation, etc. So it's incredibly effective. We have worked with the health sector across public health, adult social care, and the ICS, ICBs, CCGs, etc. over that period of time. Occasionally, it's also commissioned by housing associations or care homes, but largely it's the health sector that commissions our programs. And the programs look like it's a 26-week improvement program, followed by a 16-week maintenance program, and then, where possible, a sustainable program. And each session is 2 hours long, of which an hour and a half is the dance and a half hour is social time for interaction, but it also gives time for advocacy and for finding out whether there are other issues that need to be dealt with, dealing with other population health issues, etc. I'll shut up now, but do feel free to ask any questions.
Yeah, so any questions while we go to Max and Julie, that would be great. So we will share details afterwards. I'll put those in the circulation email after as well, so you don't get contact. But yeah, any other particular questions, then please do start to think about those. Max, you want to come to you next?
Sorry, just unmuting. Hello, I'm Max.
And I'm Peter. Yeah.
From Kinsmed.
Nice to meet you all. And the last two things we've watched, fantastic. So we got involved with the NHS in trying to improve falls prevention equipment, which was at that time basically pieces of plastic stuck under the bottoms of patients, which caused pressure sores. So what we did, looking at some research from Ulster University showing that viscoelastic memory foam prevented mattresses and cushions saw a reduction of 88.3% as compared to the control group, which was air alternating mattresses, more expensive stuff. So we developed a cushion with a sensor in it, and the cushion is pressure relieving both sides with viscoelastic memory foam. We saw reduction in falls and reduction in pressure sores. That's just from the hospitals. We haven't done a full clinical evaluation on that. We're in all of the hospitals in Hertfordshire and Worcestershire Healthcare Trust, in all of the hospitals in Buckinghamshire Healthcare Trust also, and it's repeat business. So then we got involved with the NHS, and people were asking, could you time it? And I didn't understand the significance of that. Could you time the cushion? Could you time the mattress? So this December, we'll be getting our third prototype of an alarm monitor like this, which flashes a light. I don't know if I can do it for you now. When the time set by the clinician at the back, at 5 half-hour intervals, you can do it at any interval from half-hour upwards. It also does the falls thing, so it'll do an audible alarm if you want. We'll do that with the mattress as well, so we'll be producing a pressure relieving mattress with 5 centimetre of viscoelastic memory foam top with a sensor in it. So if you ask how can you reduce, from a layman's point of view, if you ask how can you reduce pressure sores, well, don't sit down, don't lie down. So then you move from that onto the best sort of surface you can be on, and then say, as they were asking me, can you time it? Don't stay too long on it. So that's where we are at the moment with, and I could see how that might. I just looked at the traffic light system, and I loved that, some aspects of that, and how this as just one other tool may help. So, for example, knowing when to turn a patient on the side, knowing when a patient should get up for 3-minute, 5-minute walk, as the evidence shows, can really improve health and reduce deconditioning. So that's about it. It's for the clinicians then to see how they think they could use that as part of a tool. But one good aspect of it is that once the clinician sets the time that is appropriate, that's it, finish, game over. Because when the patient sits down, it automatically starts timing. When the time is reached, it will flash. So you'll know without any complicated system in a ward of, say, 40 beds and different bays, exactly when a patient needs that horrible word offloading, but they need getting up and exercising. That's about it. And we hope it can help.
Brilliant. Thank you, Peter and Max. That's really interesting. And again, we'll come back to any questions, and come back to the question that for me will be around how did you establish the connections with those healthcare organisations in the first place, and what was the mechanism that led to that? So I'm going to come to Julie. Julie, tell us all about Move It or Lose It.
Hi there, Nick. Hi, everybody. Thanks very much for inviting me to be part of this today. It's brilliant to hear what everybody's doing to make such a great difference. Move It or Lose It started in 2010. I originally was retrained to teach exercise to older people, having been a PE teacher in another lifetime. And then I was making DVDs for my class members, and I met up with Professor Janet Lord, who is the director of the Centre for Healthy Ageing Research at University of Birmingham. And we became collaborating partners to try and do more to help older people, and particularly those with long-term health conditions, to keep moving. So, long story short, we, along with these DVDs and a book, set up to train instructors to run classes. So we have a nationally endorsed training program that we call it FABS because it includes flexibility, aerobics, balance and strength, and all the exercises can be done seated or standing. So we train people to teach the exercises in their local community. We have over 400 classes now across the country, right from the tip of Scotland down to Cornwall, but we'd love to have more. And the pandemic sadly did slow us down a little, but we're picking up pace again. So along with the classes, which are very much opportunities for people to socialise as well as exercise, which is what Dahlia was saying, you know, that's so key, isn't it, to get people together for that positive mood enhancement. But also the exercises, we've evaluated the programme many times, and we can see how this brings about the tangible improvements in strength and confidence and mobility, turning back the clock by 10 years in terms of muscle strength. But it's all about how it will improve that person's ability to do the things they want to do for longer. Walking the dog, doing their own housework, would you believe, is one of the things they're really keen to keep doing. I'd like not to do mine. But, you know, doing the gardening, going on holiday with the grandchildren, things that they have stopped doing. We partnered with the Royal Voluntary Service, so very much trying to bring the home from hospital model, and we've trained hundreds of their staff and volunteers in our chair-based exercise programme, which is the one that Claire Walsgrave asked us to use for 16 of their staff at Shrewsbury Hospital, so that they can help people on the wards, part of the reconditioning, part of NPJ paralysis. And that's being monitored and evaluated, but it sounds as though that's being really valuable as well. We have an online club for people that can't get to classes that was set up during the pandemic with a bit of funding from Sport England for tackling inequalities. And that's still running, so you can come and join live classes, or there's on demand, and a little bit of an online community because not everyone can get to a class, or they prefer to dance around their kitchen in their pyjamas and not go to a community class. One of the things I thought might be interesting is the bed and chair exercises that we were really fortunate to get some funding for. And that is now on our YouTube channel. And these are very simple exercises to mobilise people in a hospital bed or hospital chair. I can pop the link in the chat and you can go and have a look. They have been verified and used in various hospitals with geriatricians and physiotherapists helping. As I said, there's no falls risk here because it is about moving shoulders, moving hands, moving feet, and just trying to boost circulation, help people make sure that when they do get up, they're a little safer if to get up, get dressed, get moving, and so on. We've worked in GP surgeries pre-pandemic for patients with COPD, 12-week programme that starts with people going, I don't know why I'm here, I can't exercise, to 12 weeks later saying, don't stop now, this is fantastic. You know, and they go to a community class and they keep going. I've still got people in my class from when I started 15 years ago. As Dahlia says, that adherence level is so important. If they enjoy it, they're going to keep coming back, which is brilliant. And we've got tons of free resources, a copper routine on YouTube, 4 things you can do in the kitchen in the time it takes to boil a kettle. It's been so popular, we've even had it popped on a tea towel, which is a nice Christmas present to remind people every time you have a cup of tea, get moving. We've got an impact report on the website. Just go and have a look, get in touch with us. There's lots more and we'd love to help you or work with you in any way we can. Thank you.
Brilliant. Thanks, Julie. So, yeah, I mean, just on that, so anybody got any questions? I've left that sort of open now too. So you've heard from the 3 organisations. I'm sure there are others, but you know, we've been connected with the 3 here through the games over the last 12 months. So that's why I want to sort of bring them in. But so got Wendy and Keely.
Hi there. Sorry, can you hear me, Nick?
Yeah.
Yeah, lovely. My question is for Julie, if that's okay. It's been really interesting to hear about what you're doing. I've read a lot online about your program, Move It or Lose It, and I think it's wonderful. What I'm wondering is about, I know you mentioned about some chair and bed-based exercises for hospitals specifically. Is that sort of targeted mainly at families and carers to sort of support with, or what kind of level, or is that targeted at really, Julie?
Originally, when we were given the funding to make the DVDs in the mock-up of a hospital ward setting by the Centre for Translational Medicine at the Queen Elizabeth Hospital in Birmingham, it was really aimed at, because of our work with the Royal Voluntary Service, volunteers being on the wards to help people to do those exercises. Of course, that had to go out. It was on an app, which it still is, but we put it on YouTube because it's easier. But it's basically for, yes, it can be family, carers, to encourage their loved ones to try and follow those. So, you know, it can be volunteers. It can be obviously any of the people on the ward and the staff as well, because it doesn't require a physiotherapist. So as long as you've looked at those exercises and can think, well, that would be safe for this patient, obviously looking at your red, yellow and green traffic light system, it may be only suitable for some. What we find it's most useful for are the people who are in their beds for several weeks because they're not able to get home, and yet they're not getting physiotherapy, which is why the reconditioning games are just so important, and just try and start the ball rolling in terms of getting that movement. But I've popped the link in chat, have a look at them, please get back in touch and I can tell you a little bit more about how it's worked with others.
That's great, thanks Julie. And if it's okay with you, I might get in touch with you. We're looking to do something with the volunteers in our hospitals. It might be really helpful if you're happy to share some of your experience and resources with me. That would be really brilliant.
Absolutely.
Yeah,
With
thank you very much.
Yes.
Thanks, Wendy. Margaret.
Oh, hi, everyone. So I work on rehab ward, and my question is mainly regarding the medical equipment. Is it King's Medical? So during the day, we do sit our patients out in the day room, and we do like a reconditioning project that we're running at the moment, where we bring all the patients in the day room. They sit on chairs, we involve families, and there is somebody designated on a daily basis to kind of lead on that recondition project every day. But then we do have patients that are not able to attend this project, and because of different reasons. So I was just listening to that the device that you were talking about that can be timed, and it can be like a prompt and reminder for repositioning the patients just to look after the skin. My question is that obviously, you know, to do with the costing and infection control, and are they reusable, and is it something that you use every day and you discard, and then you have to put another one around that thing? So maybe, I don't know whether you can just share some more information. It might be a long one, so if you just share the information with me and I can look at it.
Muted, sorry.
We were.
Sorry, that's me. Yeah.
Sorry, we're muted. Yeah, I'll do that. Surely, I'll share that with you. No problem.
You could probably answer it quickly. Yeah.
Yeah.
It's not disposable. Do you want to show?
Oh yeah, yeah. So, I mean, I'll just show you the.
So it's not disposable.
No,
yes. Oh, okay. I'm sorry.
Just to show it very quickly. That's what it looks like on the inside. This is the viscoelastic memory foam. So it doesn't matter if it gets put upside down, there's no upside down. It has the lead leading out of it, which connects to the alarm monitor. And it's simple as that, simple. And yeah, they're not.
I think we've lost Max.
Yes.
Lost Max and Peter halfway through their spiel, but I think what we picked up on from there, I think so it's not disposable, it's clearly cleanable, wipeable, but we'll get them to share the details in the in the chat. No other hands at the moment, so I'm going to take chair's privilege on this one. I'm going to ask Dahlia, and then others can come in afterwards, but maybe. Back to the question I asked about, you know, those connections with those individuals. Can we can, it's great hearing about these things, and but often the barrier is, well, how do we do this? How do we practically connect with you guys and make it happen? You know, so Dahlia, first, in terms of where you've worked with NHS organisations or care organisations. I know previously conversations we've had, you've been commissioned by the commissioners before to do that. In kind of non-commissioning arrangements, have you had any kind of connection just in terms of local arrangements that you've organised with teams?
Funnily enough, we're actually in the process of having conversations. So in fact, last week I went up and did a lecture for Norfolk and Norwich Hospital around falls and about how that works. And so, you know, it would be interesting to see. And certainly I think that one of the things, we're very much evidence-based. So, you know, we're also always happy to test new ideas. I'm very aware that there are huge opportunities in terms of, you know, the discharge to assess pathway, in terms of you know, those pathways, as Julie says, you know, getting people moving when they've been in the hospital for longer than they perhaps would ideally be, getting people moving immediately after hip surgery or knee surgery, you know, actually also working with those people who are in long waiting lists for you know, for having those kind of hip operations, etc. And there's some huge things. So I would say it's a work in progress at the moment. And it's very frustrating because you kind of get stuck in a vicious circle sometimes. You know, you can't do this because there's not any funding to do this. And on the other hand, you know, it's very difficult. You know, the Sheffield Hallam evaluation showed that, you know, we can save the NHS millions, literally millions of pounds every year.
Yeah.
But it's one of those things you have to speculate to accumulate, isn't it?
Yeah, and that's the thing that it is. That's what I'm trying to using these brilliant ambassadors we've got in this group who are the enthusiasts, and are to a certain degree they are the rebels that we want to work with and try and inspire some of the.
I mean,
go on.
Oh, I was going to say, because our program, so we deliver face to face, we deliver online, we deliver in the community, we deliver into care homes. I hope that we will soon be able to deliver in hospitals as well. We certainly got a discussion going on with an OT department in one hospital. We also have well, we do actually also have, like Julie has, some, sort of little exercises that are available online, etc. But we are very shortly going to be launching our film library, which is on demand. And that is something that I think potentially could be a massive opportunity for, in terms of nationally. Because it will have a series of different films, from short to medium to longer ones, that can be done as a build up, or they can be done as repetition, but they are all absolutely show fidelity to the PSI evidence base. So that might be a really big one to move forward with, and that should be launching in the new year. And as an online on-demand service, it should be far more cost effective and therefore easier, one would hope, to develop. And that was funded by Innovate UK.
Okay, brilliant. Gail, should I come to you?
Hello, it's a question for Julie. All of the presentations have been fab, really interesting. But Julie, I was interested when you've said around there's no physio input needed, and you could make a decision about the level of input and what you choose. I'm just really interested in how that works. I work in an acute trust and our work is on acute wards. So I'm really interested about the dynamics with that and how physio feel and who takes responsibility for the exercises, if you like, because we have a little bit of, it always prompts discussion, I would say.
I completely understand. The way it came about was working with Royal Voluntary Service, and we've been training their staff, their volunteers, and one of the volunteers, well, one of their staff was working in Morecambe Bay NHS Trust, and she then worked with their physiotherapy team to develop these exercises that were literally on a PDF, printout sheet, and the usual way, and they were trialled with over 6,000 patients, and it was great because there was no false risk in terms of trying to get people up who shouldn't be. So there is still an element, obviously, of saying, oh, that person shouldn't be moving at all. So we can't sort of say, oh, it's perfect for everybody. But because they are so gentle, so safe, so easy to follow, that it was deemed to be, well, this is a great resource. Wouldn't it be nice if we could make that a bit more visual, which is why, in a way, the DVDs work quite well because you're following along. So that's when we put it together, and it was then put onto, an app where people could go in and be doing this, as I say, family carer or somebody on the ward. And then sadly, that will stop with the pandemic. So we'd love to perhaps let you look at it, trial it, and see how you think that might work, because the whole point was we didn't want this to create more work, but to be a really easy thing that people think, that's great. And obviously even family members, when they're visiting, if it's on their iPad or, that's where you could be saying, oh, come on, let's just see if we can, let's just do these little finger exercises, let's do those shoulder movements. And the Royal Voluntary Service found it helpful because they spend a lot of time being with people as companions, And they could do so much more than just have a chat and a cup of tea by just starting to drip feed the fact that you can start to empower yourself to get the foot moving, to get your slippers on better, to be able to turn around to reach the toilet paper behind you. It's as simple as that. So yeah, but I'll pop my email address in, get in touch, and I'll just share what else I can to help out.
Lovely. Thanks very much, Julie.
Thanks, Julie. I think that's a challenge for everybody. I'm conscious of time. I'm going to come to Sean in a minute, but just that last one for me is really about, I think, between us as a group, get in touch with the team here, Julie, Dahlia, Max, Peter, just drop it, figure it out. I'm sure there's a way that we can do it. You know, it's having that conversation. Sometimes these kind of things that happen under the radar a little bit are the things that make the most impact. So just get in touch. Sean, I'll come to you for the last word, and then we'll go to Rachel.
Yeah, thank you. Hi guys, and thank you for the presentations. They've been really informative and really interesting. I'm a PSI instructor for the NHS in Exeter, so I'm part of the Royal University Healthcare down there. I'm an assistant practitioner, so working in the community, but I take the classes through the NHS at the hospital, and because of capacity, they're only running a 6-week program since COVID to get it reinstated. Prior to that, I was based at Sidmouth, and as a PSI instructor, we managed to secure funding independently, which were then hosted out. There was invitations for organisations to host it. So Sid Valley Help, which is a charity in Sidmouth, said they would like to host it, but they don't have an instructor. So I managed to speak with the NHS and say, I could become the instructor for that in my own time as a volunteer. So I now run a 24-week program, PSI, but a bit like yours. This is for Julie. So I've heard of your organisation and fantastic feedback on it as well. Do you have to show any measurements for improvement to anyone? So any funding that you secure, do you have to give back feedback on the improvement of those individuals joining your classes?
So I'll go to Julie quickly first, and then I'll go to Dahlia as well to answer the same question, if that's okay.
Yes, of course. Yes, definitely. It depends what programme. So say the COPD patients in the GP surgery is 12 weeks. We use the sit to stand test, 30 seconds, monitoring improvement. The time's up and go. So the stand, walk, turn, come back and sit down. We were very fortunate for one of the programmes to be given a quantity of times up and go, which actually gives a frailty and falls risk score. So we got a real quantitative before and after. But also with that, we get weekly diaries, because the doctors were most interested, not just in the figures, but on how it made that patient feel and how it empowered them. So we were just tracking, what would you like to achieve from coming on this programme? And at the end, did you? And as I say, it really was that I used to be able to, you know, mow the lawn, and now I just feel I can't do anything. So at the end of that, to say, I'm actually feeling so much stronger and better. I've been out, it's only the size of a postage stamp, but I mowed the lawn and the group cheers, you know, that's the thing that really we track. So yes, definite measurements, but also as much as you can on that anecdotal, really important stuff too.
So the other thing leading on to that is that the one I do in the trust is very regimented, PSI orientated, and I try and inject as much interaction and exchange with the clients. The one outside of that, I have more leeway, and I can adapt that, including the PSI, exercises. But I can adapt that and change that more into a keep fit, more entertaining, more engaging, more social on that side there, and it's been very successful. It's a 24-week program. So this is the third one I'm running now, and I've got a waiting list as long as you like. But the NHS are actually referring to me now. So after their 6-week program, they're pointing it in my direction. So I'm then taking them on, doing all the assessments, bringing them into the group. At the end of the 24 weeks, like Nick was saying, is where do I point them in to keep up with that that side of it, and what capacity do people have? Because the LED in Sidmouth are one organisation that are running another 24-week program, but they want to take them on more as a gym membership, and that environment is not necessarily what my demographic patient would like to be in. They'd like to be in that hall type environment, in that cosy feel type thing. So
Sean, I'm gonna need to wrap it up, but I think on that one, I think definitely, as we've said before, I think have a conversation with Dahlia and Julie just in terms of next steps, because these guys are the experts in terms of how they've worked before. So I think link in, drop an email, the contact details are in the chat. Carry on this conversation afterwards. I apologise, I've gone over time a little bit, and Rachel and Joe, I've eaten into your time a little bit, so apologies for that. But this was a really great, I thought this was a really great discussion, and I thought it was worth carrying on. We can definitely, if people want it, we can come back and we can carry on this conversation at the next session as well, in terms of, you know, if we feel this will be helpful. I didn't know how this was going to go. It could have been a completely silent space, but clearly it's generated a bit of conversation, which is what I was looking for. I think for me, how do you carry this on with the guys? So for now, Max, Peter, Dahlia, Julie, thank you so much for your time today. It's been really helpful. Rachel, apologies, we've eaten into your time. So between you and Joe, you've got 30 minutes. So if you can, I think I'll give you 20 minutes in the start. If you can rattle through in about 15, that'd be great.
Yeah, that's absolutely fine. Don't worry, because mine won't take as long as 20 minutes, so that's absolutely fine. I'm just getting the slides up for you.
No worries.
Yes, hello, thanks ever so much for inviting me to come along. It's an absolute pleasure to be here for all of you. So yeah, as you can see, my presentation is going to be on Max's legacy, which I've developed. So I'm a support worker at James Paget Hospital for 7 years, but more importantly, I'm also mum to Max, who I sadly lost at 20 weeks at my scan. So again, a trigger warning for anyone who may be affected by this. Please turn off if anything does get to you. So yeah, when I lost Max, the care initially was fine at the hospital, but I just struggled with the aftercare and bereavement support afterwards, and also to the staff, because what I translated as the staff not caring, it was actually that they didn't know what to say. So my mission has always been to make things a little bit better, and through the guys at James Paget and the NMAP research team, I applied for the scholarship and thankfully got accepted and was given a day a week for 18 months to develop something from what I thought I was, you know, I needed to change. So yeah, here we have Max's legacy. So I'll just present this to you. Yeah, as we can see there, through the evidence and the research and surveys I did, we discovered that 25% of pregnancies sadly ended in miscarriage, with more than 80% of miscarriages occurring within the first 12 weeks. Many of the miscarriages were unexplained, and there's a major lack of research in this area, which I found. The impact on families can be just devastating, which I sadly know, and the impact on health staff caring for this group can also be difficult. Continuity of information and support services available to families at this point can be varied. There's also been no previous evaluation of support for families and staff in my trust, so this was a completely new thing. So yeah. As much as I can see at the end of it, it was amazing. It was very, very daunting. So yeah, the aim was to understand the experiences of everyone who was involved in miscarriages, including pregnant people, their families and staff, and to make recommendations for future care, services and research, as all we originally had was a 7-hour contract for a bereavement midwife, no other care or support for anyone. And, you know, I personally felt that this was not enough. So the method I took, I collaborated and discussed with local baby loss charities. We've got Time Norfolk here, Angels and Rainbows, Sands Norfolk also. I sent surveys out to multi-professional members of staff in the maternity services. So again, not just people who worked in maternity, people, ward clerks, you know, domestics, ODP staff, fit staff who were also involved in the care when a baby loss was involved, but weren't ever considered support needed. So this survey was open from August 22nd until January 23. We also run some focus groups once a month for 18 months with relatives and families. and observations as well between May and February. So the data I got back, so we had 54 staff surveys responded. As you can see there, 2 of those were clerical, 34 maternity teams. This was again including theatre staff, sonographers, midwives, support workers, and 18 medical colleagues ranging from levels of doctors. I also managed to gain the lived experience face-to-face interviews with medical colleagues following surveys, and I arranged 2 pilot focus groups, which was attended by 16 parents and relatives. From the survey I got, we had 73% of staff have been involved in assessing, triaging, scanning a patient, a lady who maybe experienced miscarriage. All of those 73% said they felt they needed more support, with medics often feeling alone. Time between breaking bad news and moving on to next patients was cited as the biggest trauma for staff, and dealing with personal baby loss trauma. Again, there wasn't a me at this point, so they were, struggling in silence, bless them. 95% of the staff felt it would be beneficial to debrief either formally or informally after each shift. 99% of respondents would like baby loss information and training as mandatory. And all of those interviewed considered a Rainbow Clinic essential for family and support. So whilst doing the scholarship, I met lots of families, and this is the feedback what I got from them. Again, this is the staff, they were reassured every shift they saw me because they knew that they were going to be supported by myself. A lot of them said they felt it was really important that the service isn't lost, because this was originally a 4-week secondment, which I had to prove that the trust needed. Yeah, this is quite a lovely one. I'll be forever grateful for the time and care I gave them, giving them the space I needed to share my feelings safely and in an environment I could be honest with myself too. So again, the feedback we got from everybody was just humbling. And again, the patients' voices were there for the trust to know that this needed to happen. So the outcomes from my scholarship, we have now got a change of environment trialled from an A&E side room to central delivery suite for those experiencing a loss, because before my scholarship and my work and Max's Legacy, people were seen downstairs up to 16 weeks and, being stuck in a little pokey cupboard with a curtain on is not the place where you not only should have to lose a little one, but also it's not nice to be told sometimes heartbreaking news. So now we see them up on CDS, which is like a bit of a groundbreaking moment, actually. I run a formal monthly support group every month for parents and families, and I had one last night and we had new people come again. So again, they're praising the support from the group what we developed. The trial of a bereavement support worker role, which I had for 4 weeks, but I'm now, thankfully I'm now in the role permanently because of the evidence I produced from Max's Legacy. I've also been invited to speak to several conferences, the Norfolk and Waveney ICS Research Conference, the Chief Midwifery Officer Research Launch, Time Norfolk Baby Loss Study Day, and the Maternity Support Worker Conference in Birmingham. Through my work, I've also been awarded the National Chief Midwifery Officer for England Maternity Support Worker Award, which I was the first support worker in the country to receive this, normally as, midwife level, but the work they saw, the results I achieved, they sort of said it was worthy of this award. So again, I'm very grateful. I was awarded one of the Reconditioning Gold Awards with you guys, which thank you very much. It's got me to this point. I also formally collaborate with local charities and have a very, very good relationship with those. So with our families and staff, if they do need any support, they've only got to just come to see me or email me and I can link in straight away. So, as I said before, I left here with no support whatsoever, whereas our families and staff know if they come and see me, I can get them that support, counselling tomorrow. And just the increased communication and discussion with staff about the impact of baby loss, because again, what I interpreted that people didn't know what to say, the training wasn't there or anything, so now I'm putting it into place in this role that the training will be there for staff at all levels in what to say. Yeah, this is the poster I developed, which I present at several conferences. So these have been the slide and the QR code if you did want to have a look. It's another poster. Yeah, I'm also proud that the work I've done with Claire Whitehouse and Kirsty Cater and Heather Rostrom, we went on to actually get our work published in the British Journal of Midwifery, which if you'd have said to me 2 years ago that I'd ever be a publisher, then I'd never have dreamt it. But yeah, again, it's up there on my one of my worrying moments, and that can be seen on the link as well. I was also awarded the James Paget Golden Patients Awards just before Christmas at Paget, which again, it was amazing because it was voted for by the patients, which, you know, that means more than anything to me. Yes, as you can see there, the recommendations from my work. So we're absolutely hoping to get a rainbow clinic here at James Paget as we have at Norwich. And again, the work, what I've done and the evidence is straight in front of us to be able to give to the trust, and hopefully this will be happening anytime soon. They've actually continued the bereavement support worker post, which I'm now in. So I developed a job description, business case, applied for the role and got it, and I'm now week 3 into it and already seeing lots and lots of differences. The monthly group, like I said, was last night, so that'll be an ongoing thing, and every month we get more and more families, and that's, you know, that's such an amazing place to be for myself and the families. It's just humbling. And again, I collaborate with local charities and trusts in the region, so I'll be speaking at James Paget here for our little baby light service on Sunday, and I'll be at the Time Norfolk one at Colney next week as well. So just them links are just there now. So yeah, as for research and evaluation, we're just going to carry on going, working with the National Bereavement Care Pathway. We can hopefully continue to make lots of changes. These are just acknowledgements of people who I couldn't have done any of this with. You know, they were all absolutely amazing. I can never thank them enough. And here's just a little final poster from baby Robbie, just to say, you know, it doesn't matter whether it's a loss at 1 week or 40, every single loss is, you know, should be valued, and the care and support should be there for everyone.
Thank you, Rachel. That is really great work. Well done. Really fabulous work. Thanks for sharing that. That's and obviously thanks for the work. Anybody got any questions for Rachel? Just you can pick up Rachel's email off this invite and the chat. So please get in touch if you want to find out any more from Rachel and the great work that to do in James Paget. So thank you. Really great stuff.
Thank you.
Yes. Joe, are you still on the call?
I am. Hello.
Fabulous. How's your IT at the moment? You said before you're having a bit of struggles with sharing.
Teams has been a nightmare all week. I'm going to try and share my screen, but it might be that no one can see it. So I'll give it a go and quickly tell me if you can't see it and put thumbs up or whatever. Can you see that?
Yeah, it's there. Thank you.
Okay, cool. Now I can't see where the slideshow is because it's hidden under there. There we go. Lovely.
Over to you.
So I'm not going to run through these slides in detail, but what I wanted to explain is kind of what we're trying to do locally, and then see if anyone else is working on things similarly in other areas so that we can share learning. So at Nottingham University Hospitals, we're running a deconditioning task and finish group, and we're kind of focusing at the moment on how we educate our staff about the risks of deconditioning, and also how we can measure risks. So this deck is a slide deck that we're currently developing to try and educate our staff, and it's only going to be one part of the education because we're thinking we need to do more than just a simple slide deck. So some of the other things we're doing is we're working with the dietitians, so they're doing some mandatory training, so we're looking at deconditioning in relation to nutrition and hydration. We're working with the back care advisors, so they're now talking about deconditioning when they do everyone's inductions, and we're working with all the HCAs as part of their induction and delivering a similar slide deck to this, but not exactly this. But this, as I say, is under development. It's all kind of been borrowed with pride or invented from scratch, but it's all publicly available information. So we start with a little bit of a overview, and then we share the Mrs. Andrews story, which I'm sure you're all familiar with, but if you're not, the link is just there. It's just a story about it always makes me a bit weepy, about a lady who kind of came into hospital and had a series of deconditioning moments in her journey from home to hospital to back home. We've got a definition of deconditioning. So the definition is actually a very tricky issue. We're working with a PhD student who's looking at deconditioning definitions at the moment. So we're using this one by Amit Arora, which kind of sums up how complicated it is. which means measurement of it is very difficult and risk assessing of it is very difficult just because there's so many factors involved. Then we talk a little bit about the background around inactivity and why inactivity is bad for us, and how we should be breaking that up, and that's we kind of emphasize how that's the same for all of us as well as patients in hospital. But then we run over the issues that happen when somebody comes into an acute ward, and we run through it. This is slides, it's with comms at the moment, they're trying to make it look pretty for me, but this is a slide where we talk about all the bits that are impacted on by deconditioning. So it's not just about, you know, reduced ability to walk and increased risk of falls or pressure damage. It's about constipation, continence, confusion, disorientation, impact on that. You can see it's, and you'll know it's all these different factors, and we explain all of that. Then we've got some of our statistics around kind of discharge and disabilities in activities of daily living. Then we've got some of the benefits of why being physically active is good for us, and again that's general population stuff, but we talk about it in relation to our patients. We talk about how as we get older we do less, so when patients come into hospital they will already be to some extent deconditioned, and how we need to identify that and kind of work with people who aren't normally very active. Run through kind of what physical activity is, what the guidance is, and then how going from just doing nothing to doing 5-10 minutes is really beneficial for people, and if we can instill that as behaviour that's going to be beneficial in the long term. Bit of stuff about what's physical activity for patients while they're with us, so personal care, chair exercises, going for a walk. And then we run through what we can do. So we reference reconditioning the nation, we reference NPJ paralysis, talk about giving patients something to do, so a reason to get up, a reason to be cognitively stimulated, all those sorts of background things. And then locally we have got this programme where we have bed and chair exercises, and we have volunteers going out to do these with patients, and this was a co-produced sheet that we developed with the PPG. It was runner-up in the Penner Awards this year, so it's been doing the rounds. It's available on our website if anybody's interested. It's got QR codes on it, physio demonstrations of each of the exercises, and as I say, we train volunteers up and they go to 4 of our wards and do these exercises with patients at the moment. So we're just trying to expand its use within the hospital, and that's the slide deck. So I suppose what I was really looking for from this, if possible, was to see if anybody else is developing their training for within their individual trust, and see if anybody wanted to do a bit of work on this together, so that we can kind of pool resources and share learning. And also if anybody wants to use any of my slides or use that keep moving sheet, you know, just let me know. And I talked very quickly because I'm aware of time, but that's that.
Brilliant, Jo, thank you. So we have got a little bit of time. If anybody has got any questions or wants to respond to Jo's ask, if anybody's doing anything similar or wants to collaborate, jump in. Wendy and Keely, or Wendy and Keely, or Wendy.
Yeah, sorry, Nick. Wendy's gone now, so it's just Keely now. Hi, Jo. Nice to meet you.
Hi.
I'm really exciting in my newish role still as the prevention of deconditioning therapy lead at Bedford, and I would definitely be really keen to, if possible, collaborate with you on some of this. I haven't quite got to where you are yet, but I've had a lot of ideas about what we could do. I was particularly interested about the fact you're saying about the kind of classroom teaching, but how does that actually translate and transfer into ward-based care, and how do we do that? So yeah, if you're happy to, I'd be more than happy to work with you if that's appropriate.
I'd love that. Could you share your details, because I can't see your email when I click on you. I can't see it.
I'll pop it in the chat for you, Jo. Okay, and then feel free to email me whenever you're available.
Lovely, thank you.
Okay, lovely, thank you.
Thank you, Keely. So quick question from Amy in the chat. How many volunteers have you trained up, and how long was their training time?
So we've trained up in total, I think, getting on for 20, and at any point we've had about kind of 10 to 15 on the wards, because obviously they come and go. So we approached students primarily. Primarily we're working with sports exercise medicine students, or sports exercise students, sorry, and my post is due to come to an end in March, but if it ever got extended, we'd be working with physio students as well. We give them a training session, and then we do 3 observations. So they see me do it once, I go through it and watch them do it 3 times. And that tends to take us over kind of a month, but it's kind of in 2-hour chunks. So 2 hours for training and then 6 extra hours for the competency. So about 8 hours in total from me. And then I give them ongoing kind of support. They do kind of keep records just for audit purposes, and something very basic that goes into patient records, so they have to know how to do that. And we just explain how to do the bed and chair exercises to them, and kind of run through contraindications, risks to the patients, how to spot if someone's becoming unwell, confidentiality, infection control, all those things we kind of run through with them.
Brilliant. Thank you, Joe. That's helped. Amy. Gail. You're on mute, Gail.
Sorry, it was just echoing what Kaylee said before about interested to hear a bit more offline, and I'll share my email address because I showed interest before there with Julie. The exercises on an acute-based ward are really of interest. We started going with NPHA paralysis in its infancy when it first was created, and we've faulted slightly for all of the reasons we've all talked about this afternoon. But it's trying to get back on board with them, and I'm really interested about not so much accountability, but where does responsibility lie and who's going to take ownership. And the ownership is the big thing for us about how do you do that and the expectations. And if it's volunteers, where do you sit with all of those things? So I would be really interested in maybe collaborate or talk about that or whatever. So I'll put my email in the chat. So thank you very much. It's really good to hear.
We're trying to come at it from an MDT angle. So as I say, we're kind of getting involved with dietitians as well as physios and OTs, as well as nursing staff and HCAs. We've also got speech and language therapy coming to the deconditioning task and finish group, and then we've got the volunteer wing to it as well. So we're trying to come at it from every angle we can think of. But it's obviously it's a challenge to try and change culture, isn't it?
Yeah, and that I think is one of the hardest bits.
It is, and just on that point, it is about keeping on. This is why this is a social movement rather than a policy that we're trying to prescribe to people. This is just about repeating the same thing but doing it slightly different, or just repeating the message that we've heard before about. Sometimes we heard from the guys at South Warwickshire, sometimes you just have to be a bit stubborn and just keep on, and that's what we're doing here. And that's why I'm so encouraged by this group of ambassadors that there's around 400 across the country that sort of connect with this group. That you will be the guys that sort of move things forward a little bit. There won't be any policy from the centre that does this. This will be about just people getting on. So without wanting to overwhelm Joe, if you want to get in touch as well, create that sort of little community of practice. I'm really interested in the evidence-based stuff, the data that sits behind this, proving it, because we all know it in our hearts. But there are still many people out there who they believe it, but they need some data that's going to back it up. So the measurement work that I know that Joe, Anne-Marie Riley, who's been on the call as well early on today from North Staffs, has also sort of linking in with. There's some really good work going on this. So anybody else who wants to join that party, please do. So thanks for that. As promised, I'm going to sort of draw things to a close. I will share all the slides that we've gone through today. All the contact details I'll also include in that email that gets sent around, and I'll also put a link into the recording so you can share that around with everybody else as well. Once again, thanks a lot all for your time. I think it's been a really interesting conversation today, and I think it really brings the value of the purpose of this network, this meeting together. We've got penciled in the 25th of January. I'll send out the invite for that some point in the next few days for our next meeting. On the agenda at the moment, I've got a couple of things. Update from Jackie Holmes from Birmingham, who's done some great work in Birmingham, and also one of the asks was to learn about how we've engaged with students. So Helen Rostron from Devon, I think, Somerset, to get the right county, else I'll get shot. Helen Rostron worked with students at the start of the reconditioning games, so she's going to come along and share how she did that and how she's worked with students as well in that. So a bit of a prep in terms of some of the questions you may want to ask on that one. But thanks a lot for your time. Have a pleasant rest of the afternoon. We won't see you before, but have a great Christmas and New Year. Hopefully you'll get a little bit of downtime and spend a bit of time doing what you want to do. So for now, thanks a lot, and we'll see you in January.